Welcome and good evening to this monthly webinar series hosted by Association for Harm Reduction, Education and Research. In this new year, 2022, we are hosting Dr. Sivagurunathan, Associate Professor, Department of Community Medicine, Tagore Medical College and Hospital, who is going to have a moderated discussion with us on the topic of tobacco and transgenders in Chennai. In this discussion, we are going to focus on the pattern of tobacco use and associated socio-demographic factors among transgenders living in Chennai. Welcome, Dr. Shiva.
Yeah, thank you, Dr. Sri, and thanks for the invite. Happy to be here. So, yeah.
It's a pleasure to host an epidemiologist and co-public health expert on this forum, because this forum typically hosts multidisciplinary specialists from behavioral science, health economics, and in the past we hosted clinicians and psychiatrists as well as journalists. And today, to start off this year, I also belong to public health department as well as an epidemiologist, and in the past 5 years involved in specialized research among low-income groups and vulnerable populations. And today, this topic is very close to my heart, and that is focusing on LGBTQ community. And in that entire spectrum, we are talking today about tobacco and transgenders in Chennai. I'm happy to host this discussion with you, and I would like to begin this discussion today. Dr. Shiva, can you share your understanding when you looked into this topic? What is your learnings as well as your sharing today about the tobacco epidemic at global as well as national level? Can you share your understanding about this?
Yes, yeah. So today's topic is tobacco and transgender. But the data about transgender is very limited when we go through. When we do this literature review, it is very limited, and data about general population is available. And tobacco, as you know, uses the highest and biggest threat to public health, and all form of tobacco is harmful, and like no dose is safer. Any dose, any form is harmful for human health. So with that, it's about 1.3 billion population. I mean, people is using tobacco globally. In that, 8 million people dies every year, and 7 million people dies. I mean, in that 7 million people dies due to direct use, and 1.2 million is due to second-hand smoking. This is like something we have to note. 1.2 million they die because of someone's fault. Not because of their fault. And in this 1.3 billion, 80% lives in low middle income countries like India. 80% of the users. And so coming to India, comparing with the rest of the world data, rest of the world, we see about 90% of the users. When it comes to tobacco use, it goes with cigarette smoking only globally. 90% of the users smokes cigarette, a branded cigarette, that is legal cigarette, from an organized sectors. But in India, it is on the other side. Like in India, only 9% uses this organized products from the organized sectors, and about 91% uses products from unorganized sectors, like products like BD or smokeless tobacco, like chewing tobacco, gudka, zarda, like that. So this is very unique, and being a second largest country of tobacco production, and we have uses considerable number, over 26% uses tobacco product, but the per capita consumption of cigarette, India is among one of the lowest. Like it is 89 cigarettes per annum. If we look into the data, China, it is around 2043 cigarettes per head, per capita cigarette consumption per annum. and Japan it is around 1,500, US is around 1,000, and UK is around 820. And if we compare our neighboring nations like Pakistan, it is around 360, sorry, and Nepal it is 500, and Bangladesh it is around 700. But since the use of organized sectors, products from the organized sectors is very low, India's consumption rate is very low. It is only around 9%. And as per a global adult tobacco survey in India, the tobacco consumer base in India, in any form, tobacco consumption in any form, consumer base is around 28.6%. But the adult cigarette consumer base is only 4%. So, in the last 3 decades, the legal cigarette consumption has been reduced in India, but other form of tobaccos like smokeless tobaccos and BDs, it has been increased drastically.
So this is a very interesting way of looking at tobacco consumption patterns in India for general population. And I believe when you stop there, I think you could not get such data for transgenders. Is it?
Yes, the data is very limited. That too, like as I said, the consumption of smokeless tobacco is high in India. We have 1 or 2 studies in India on consumption of tobacco products among transgenders, but the focus on the smokeless tobacco is almost zero, I would say. So that there is no focus on smokeless tobacco, but that happens to be the form which is liberally used by general population and also the transgenders.
Okay. So because as you just mentioned, the predominant tobacco product consumed globally being the smoking form,
yeah,
though the smokeless form of tobacco is the predominant form, 91% in India, even then there is a gap in understanding the literature, or the statistics are missing from the public sources when researchers want to completely understand where all these pockets of consumption are there.
Yeah, and the studies which are available as small sample size studies, and we can only get 2 to 3 studies in India. With that, we cannot arrive at any conclusion. And
yeah, you have mentioned about global data, and also mentioned Global Adult Tobacco Survey, second version of India. Are there any data points available for Tamil Nadu about general population's tobacco consumption patterns?
Yeah, in Tamil Nadu, there is a survey which has been done in 2015-16, Tamil Nadu Tobacco Survey. And in Tamil Nadu, the current tobacco users are around 5.2%, and that current smokers are 3.3%, but the cigarette smokers are, again, it is less, 1.7%. And smokeless tobacco users is around 1.3%. Almost India, the data, we can compare India data and Tamil Nadu data, it almost goes hand in hand.
Okay, so it is reflecting the national trends.
Yeah.
Yeah. Are there any differences between rural and urban consumption patterns? Because generally, typically, I'm assuming that urban people being more educated or employed, they would prefer a different tobacco products. Is it true?
No, there is no difference in consumption among this urban and rural users. It is almost similar, 26 and 26.5. It is almost similar.
Okay. So coming to the today's topic of interest, when we are talking about vulnerable population groups like transgenders, what is your research or review of literature sharing about this population?
Transgender, they are prone for abusing tobacco, alcohol, and other substance as a coping mechanism for their minority stress. Minority stress is something which is specific to transgender, they experience socially or in their workplace, um, uh, other than what the general population experiences. In addition to the general population's stress, they have their own specific stress to handle. To cope up that, they use tobacco products, alcohol, and other um, substance of abuse. So they are prone for this smoking as well, use of tobacco, smoking in smokeless form. And the studies which has been conducted in India shows the high prevalence of current tobacco use among these transgenders.
Okay, when you say current, it is means like in the past 1 week or 1 month?
1 year.
In the past 1 year, in the entire period of 1 year, they are currently using any form of tobacco.
Any form of tobacco, yeah.
Okay. But what is the gap in this kind of studies currently done among transgender communities? Because we discussed this because we are currently going to very shortly share our study findings. But what are the current gaps in the existing studies when it comes to transgender and tobacco in India?
Yeah, as I said, the number of samples, the sample size is very less. And it has been, the number of studies also very less.
The challenges when we are talking about these vulnerable populations, when people are doing studies, the small sample size and the number of studies being 1 or 2, especially in Tamil Nadu, we came across 1 or 2 studies and 1 study from Pondicherry. So when such lack of studies are there, can we really understand the entire burden of tobacco problem among these vulnerable populations? Because we just discussed these populations are subjected to minority stress, additional stressors in coping their stigma and discrimination, low livelihood opportunities, lack of education leading to low livelihood opportunities. So with this kind of scenario, lack of research, lack of focus in understanding the entire gamut of problems leading to the tobacco plus additional substance abuse shows that we are neglecting them who are already neglected.
Yeah, and the studies which has been done, they as I said, it is focusing only on the smoking form and not on the smokeless form. But the usage is high when you compare the smoking form and the smokeless form. I told you it is 90%. They use only smokeless form, but we don't have proper data on that. So without data, we cannot plan policy or program for them or to do harm reduction or rehabilitation. Nothing can be done without understanding why they are using it, how they are using it, and what they are using it.
Exactly. That's a very valid point you have made. So let us also understand what kind of methodologies and what kind of data supporting needs to be done, because you alluded to policy making. Whenever policy is currently made, because we come from a policy background, being in public health and epidemiology, you also have worked in 108 before being an academician in the Department of Community Medicine. You worked in trauma care and all those things. When such services are planned or such policies are made, what kind of evidence goes into planning such services? Do you just sit around the table, call a bunch of experts and design policies? Or you look into evidence, and for that evidence, you conduct some research? What is the flow of this process actually?
Yeah, see, you can do any policy. We can form any policy. End of the day, you need budget.
Yes.
So to convince the bureaucrats, to convince the government, you need to show some evidence that this is a major threat, and this is putting this much burden on our health system, and we are spending so much of money in treating money and resources in treating these particular disease. So if we invest and prevent these disease, so that we can save this much resources, we can save this much burden on healthcare, and as well as, like, if you save a person, you can, if you reduce the morbidity and if you reduce the mortality, who happens to be a breadwinner of the family, so that family can survive. So all these things we have to convince the bureaucrats before. Just like that, we cannot make a policy and we cannot run anything before coming to the policy. Before that, you need to conduct a study, you need to do a survey, and we need to find out how much burden this particular disease creates on the health sector and the government. So with that, and we will do this field survey, and we will try to split it into blocks so that we can plan which block need what kind of service. It is not like entire government, you cannot or pan a blanket, we cannot do a policy or a service cannot be delivered like that. If we deliver service like that, we're going to waste so much of money. Okay. So we need to break into blocks, and we need to plan for according to the need of the blocks. So it can be A, B, C level of treatment. For some blocks, A level of treatment is sufficient. In the sense, we will try to adhere to that treatment itself, so that we will save some money and resource, everything. So you need to do a survey. We need to have a evidence proof, and we have to convince our bureaucrats, and then only we can make a policy.
Okay. When it comes to tobacco-related mortality and morbidity, there is convincing evidence already that, as you said, 80% of the burden is in low and middle income countries. And with your own data points revealed today, 91% of that is coming from smokeless tobacco. Right. And for this population, because today we are focusing on transgenders, what kind of studies will generate credible evidence? Because all of the existing literature is small samples, 100, 150 sample size, and only 1 or 2 studies, or even if we say generously 5 or 10 studies are only there. Such small number of studies, will they be enough for the policymakers to be convinced to adopt any credible policies? Or we need to undertake big, large sample-sized studies with the evidence like generating 2,000, 3,000 sample size results, and we can create a policy document or a policy recommendation to the, because this is a vulnerable population, right? Yeah. So what is your opinion on that?
So like, you need a good number of participants for your study. The sample size should be sufficient. It is not, you need not to have a large samples and all. It is not like if we include our 5,000, 10,000 people, we have studied everything about the transgender. We cannot claim that, but you need, either way, it should not be less. It should not be, if it is less, you'll not get a proper result. If it is more, we're going to waste our resource. That's all. But ideal number of participants, and before that, we need to know, we need to do a qualitative study, and we need to know about their needs, and as I said, why and how they are using these products, and we need to do a study, and we need to have a questionnaire, so that we can do a 360-degree study about these this problem in transgenders, so that we can have a good data. With that, we can do a proper analysis, and we can arrive at a conclusion. We can give some recommendations for this particular group.
Wonderful. Now let us move on to our current ongoing study in which we both are involved. And you have been part of the study at analysis level as a data scientist. And we are looking at one data set where we have good number of access to some number beyond 100 and 200 numbers. So what are your preliminary observations from that data set? Could you share the major important points from the data set which you are currently analyzing?
Yeah. this data set, like any other study, we have covered 5 major determinants of transgenders, like their demographic details, the details about the social exclusion, their body transformation procedures, their tobacco use, and access to health services. So we have under this, we have 30 to 40 data points, and we have broke this data into more than one study, and we are trying to give good details in this paper. So coming to tobacco use, this study has, as you said, it is more than 300, 400 participants, and the mean age is at 33 years, and around 78% are from rural areas, and 80% of the study participants have been attended or passed 10th standard or above. So this is an important factor, that most of them are actually crossed secondary level in their education. And coming to socioeconomic status, we have adapted the BG Prasad classification, since we have the rural participant and urban participant in our study. Only this particular scale will allow us to study their socioeconomic status, and with only one determinant, that is their income. So we use this scale, and 80% of them is falling in upper class with their income. And current tobacco users in this study is around 60%. And smokers and current smokers are less than 15%, and smokeless tobacco users are more than 50%. So again, it is following the same trend in Tamil Nadu and India. And about 60% of the participants have started smoking before the age of 20. And coming to the nicotine dependence, 28% of the participant consumes any form of tobacco within 5 minutes of waking up. And 40% of the participants have some health issue which is related to tobacco use. And 53% have noticed the warnings on the pack, but it is of no use. They continuously using this product. Okay. They don't follow this. It is just a custom. It is in the packet, but we don't take it seriously, I guess. And they are continue using it. Around 27% tried stopping this habit in the past 1 year, but they have not stopped it. And around same person, 28%, they have an intention to quit smoking, but they are continuing using it. And coming to the important part, only 3% of the study participants know about this availability of alternative. So there is no proper knowledge about harm reduction and other products which is available. I guess the availability of the alternative products is not that in India. I don't think it is available in India. Yeah. So 1% shows interested in trying low risk alternatives, only 1%. And we see an association between.
Let us take a couple of minutes to look a little bit in depth in these data points, because you said the current use of any form of tobacco products is around 65%.
Yes.
Right? It looks like a very alarming percentage for us to be worried about. Already they are vulnerable population. Yes. And if I remember correctly from reading the literature, the tobacco use among LGBTQ or especially transgenders is reported to be 3 times higher.
Yep. Yeah.
And you told me in your opening remarks, GATS2 for general population across India is 28.6.
Yes.
And this is 65. So it is almost equal to 3 times higher than the general population rates. And going by this standard, now you are coming to the another point where you are also telling they are using these products before the age of 20 years.
Yes.
So this long exposure and the average age, mean age of our study population is 33 years.
Yes.
So connecting all these dots, someone is starting at 20 and mean age of our study population is 33 years. And they are continuously using smokeless tobacco products. And in a country like India, smokeless tobacco products are of wide varieties. As you yourself quoted, Kaini, Panpara, Gutka, whatnot. So with all this combination of mixing and matching a variety of smokeless tobacco products, there is no profiling of toxins and the exposure to these toxins. And because of all these things, it looks like a very good ideal combination for them to be exposed to this variety of toxins. And as you said, they have no awareness about reduced risk alternatives. And it looks like a very worrisome picture to me. And this is where we need to really understand what is the scenario and where is the way forward for us. Right?
Yes.
At this point, if you have to really understand, almost 1/3 of them are already addicted because 28% subjects already said within 5 minutes of waking up, they are consuming a tobacco product. So that is an indicator of nicotine dependence.
Yeah.
So with all this indicators, we try to extract data by interviewing these subjects. Transgenders and tobacco use in Chennai looks like a topic we have to be working on, right? And if we have to really make an attempt to bring about a change, we have to start somewhere.
Yes.
And if you want to address somewhere, now let me listen, what are the associations you have found out when you try to do logistic regression?
Educational status, socioeconomic status, and occupation has a significant association with current smoking status and trying to quit.
Okay. So
yeah.
Can you explain how that translates? Like if someone is highly educated, someone is having a better pay.
They are less likely to go for this habit, tobacco use. Okay. Likewise, if they are in upper social class, they are less likely to go for this habit.
Okay. Is it more about a habit or is it more about nicotine dependence? Or I think we need to also a little bit understand if someone is low educated, someone is having a low paid job and someone is having low motivation or willingness to quit. Those are the groups predominantly not having access and awareness to this reduced risk alternatives. Yeah. So through our interventions, maybe tobacco harm reduction strategies should be targeted with some kind of specific messages to this population.
Yes, absolutely. So we need to have a high risk approach for this population. Like they don't believe everyone because we have isolated them, whether we like it or not. They have not been included in the society and they have not been given the proper recognition they require. And even wherever you go, they have the inhibitions and they have the fear of getting under the stressors. So because of that, we need to have a proper plan, and we need to do a BCC, that is behavioral change communication, for this group. We need to involve people from their own community, that is transgenders, and we have to educate them, and we can spread message through them, which will be very effective. Rather than we going and talking to them, they look us like they might, maybe I'm not that experienced, but you have experience with this transgender community. They might look us as a different person or like an alien. So if we involve those persons, those people, and if we can, we have seen a lot of educated people like lawyers and all. In this particular study, we have seen a lot of people with high qualification, PG degrees. We can able to reach them, and we can able to talk to them, so that if we can able to spread message through those people, and if we able to find out what are the reasons for this particular prevalence, that is highest prevalence of tobacco use, and then we can plan for remedies, that recommendations with which we can rehabilitate these transgender people.
But coming to Tamil Nadu, Dr. Shiva, Tamil Nadu is one of the most trans-friendly states in India.
Yep.
And every year, even this last year, it has won the award from the government of India for the state being most trans empowering as well as trans friendly. So in that kind of context, when special programs are being designed to include transgenders and empower them, with this kind of data, maybe we should also try to bring this awareness among, as you said earlier, first create a research plan, generate evidence, then go and communicating this evidence to the respective authorities, so that they also become aware, like there is this burden, that there is this need among the transgender, these various dimensions of low income group abusing smokeless tobacco product is the need of the hour, and bringing this targeted approach to bring behavior change communication strategies, raising awareness by involving their own community members. Variety of strategies maybe we can bring out as a policy document or a handout or a report, so that they may consider it without investing too much of their energy. We are giving a ready-made solution for them to quickly adopt, because already we are empowering trans through some welfare schemes. So maybe they can include, because already for HIV, they are doing harm reduction through condom promotion programs and HIV testing every 3 months. All transgenders registered in the HIV National AIDS Control Organization program, TANSAC, Tamil Nadu State AIDS Control Society, does HIV screening, infectious disease screening. Similarly, for tobacco, we can also advocate for tobacco harm reduction. What are your thoughts about this?
Yes, definitely we can do it. As you said, we need to have a proper plan, and we need to have evidence, and with that evidence, we need to draw recommendations, conclusion and recommendations for this particular group. And with that, we can put a plan, and we can deal with them. And strict enforcement of law is also required. See, in India, the smokeless tobacco is almost banned, right? But
almost.
The uses, So, but see, they are liberally using this product. So from where they are getting it? So we have to strictly enforce law. And being an unorganized sector, they are producing a lot of this tobacco products, and they are circulating in the community. And how, if it is not accountable, how will you go and catch them? How will you restrict them? We say like it is banned, but the study shows different picture. Not only in our study, any other studies, and even government data says like smokeless tobacco use is higher in India. It is not in any other country in the world. So it says like we are giving access. There is an access for this particular products, and we are not aware of them. So first we need to have a proper plan to restrict this access, and we need to maybe we have to bring it to zero access, so that the usage can be reduced. So strict enforcement of laws important, and BCC, behavioral change communication, for this group is important, with which we can easily mitigate these people.
Yes. And coming to the other data point, which we were looking in the table 3, are you currently interested in quitting tobacco? Only 17, almost nearly 18% are only interested in quitting definitely. So it looks like there are other categories of people who are right now definitely not considering quitting tobacco
Yes.
use. So there may be some kind of reduction, but they are continuing to use the tobacco products. For such group of people, tobacco harm reduction is the way forward.
Yeah.
Because they are
One is like health education, awareness about the harmful effects of this product, and another one is like therapy.
Yes.
So we need to give them alternative ways to cut down on this tobacco products.
Yes. So in that format, the alternative options available right now in India are nicotine replacement therapy products like nicotine gums, nicotine lozenges, nicotine patches, which are available in the pharmacies. But for this particular group, like transgenders, because of their socioeconomic factors and other determinants, accessibility, availability, affordability, these are the most important constraints or barriers. Even if we raise awareness, affordability could be a key determinant. So what could be the policy dimension we can advocate, because they're already having some kind of advocacy space?
If government realize this is an important way through, like this is an important way to mitigate people, they can deliver it for free. There is no issues. Nicotine comes. We are doing a number of free services, and with that, you can easily do that. We are also, as you said, condom has been given for free, right, in government hospitals. Then why can't you give nicotine gums?
That's what, there is at least some leverage when it comes to transgender community, because they are identified as a key population for certain high risk behaviors, right?
Yes.
So using that space, maybe I'm hopeful that our kind of research with the large sample size, identifying the real crux of the problem, covering like 30-40 data points and analyzing the data with all these dimensions, going forward, if we can take this to the authorities and present the data and able to have a negotiation with them about the importance of translating this research into some kind of policy measure, because this community is already having that space for policy level advocacy. Every day they go for some or other welfare scheme, for their ID cards, for their welfare measures. So in that space already, because of the other harm reduction measures going on, I'm hopeful that with our discussion and our data, we will be able to move the discussion forward. Now, coming to the accessibility to other services other than pharmaceutical components like nicotine gums, there are no other options. Like when it comes to consumer products, right now in India, we don't have such choices. Do you believe there is space for such products where consumers can go and negotiate for other kind of products? Like nicotine pouches and other things we read in literature, right?
Yeah, but I don't think it is purely the decision makers, the bureaucrats' opinion. Some of the countries have legalized even this nicotine delivery system. They are approving this system that it is helpful for as a therapy, not for everybody. It can be, it has been approved as a therapy for withdrawing cigarettes or along with nicotine pouches or gums. But right now in India, there is a lot of restriction on that, and we have only this gums and lotions and pouches. To my knowledge, I don't think it is available in India. Is it available in India? Pouches?
Yes,
legally?
Yes.
Legally it is available. Okay.
Yes.
So with that we can the users like whatever it is, we have to deliver it. We can deliver it, but you can give a tablet or you can give whatever you want, but they should be satisfied physically and mentally. They have to satisfy themselves. It is smoking comes to smoking, it is purely psychological dependence rather than physical dependence. So we have to consider all these points too. So then
Yeah, when you talk about these various dimensions of dependence on tobacco products, when you put the transgenders in the center of this issue, what are the other holistic services we can plan for this vulnerable population so that they will also benefit from this? Earlier you mentioned 360-degree approach for undertaking research. If you have to deliver a complete package of services for tobacco prevention, control, cessation, as well as harm reduction, what are the entire package of services you envision for this transgender community?
Mental health services. Exactly. We have to couple this with not only like treating this is a big challenge, and you need to have a psychiatrist help to take them out of this habit. So we need to couple this along with we can deliver this with mental health services, a psychiatrist, and with maybe a preliminary checking for cancer. And as you know, smokeless tobacco have it will increase the incidence of cancer, tongue, oral cavity, and even other disease of oral cavities, throat, the head, neck. There is a lot of evidence against this. So we need to have a preliminary check for them, and do they have any stage 1 or stage 2? If we find it earlier, we can treat that as well, along with harm reduction and counseling. A psychiatrist who can advise medicine, a counseling psychologist can give counseling session, so that we can easily mitigate these people.
So very valid point you have brought up, Dr. Shiva, because February 4th is the World Cancer Day. We are commemorating very soon next week. And in the context of 91% of tobacco consumers in India being smokeless tobacco users, comprehensively planning services with behavioral modifications, as well as counseling services, lifestyle modifications, and oral cavity screening, because they are using these products in the oral cavity. This kind of comprehensive integrated package of services, I think going forward could be the best way to address this entire harm reduction, not just tobacco harm reduction in the sense of tobacco product alone, but the entire damage that can be resulting from tobacco product usage. Apart from this, when you talk about transgenders, they fit into the spectrum of LGBTQ, where they transition from a biological gender into a different gender. And they also, as you mentioned, undergo gender affirming surgeries and feminization procedures and hormonal intake that also interact with this tobacco product and other prescriptions. So we need to be looking at this population which is deserving more attention than what it is receiving right now. Yes. So going forward, what are your broad messages when it comes to reversing the tobacco epidemic? Because 2025 and 2030 are fixed as the endpoints to reverse a certain proportion of deaths resulting from tobacco, whether it is for non-communicable diseases such as hypertension, diabetes, cancers, as well as related to tobacco directly causing certain mortality and morbidity. Right now, India looks ill-equipped in providing this entire package of services. And I also remembered one more data point when you're talking about providing the evidence to the policymakers by telling, if you prevent this, you can save that much. It is mostly about health economics and health expenditures. And the data point from United States, especially from New Jersey, because I was attending a webinar last night They say for every $1 spent on tobacco prevention saves them $55 on tobacco treatment.
Yeah,
So
absolutely.
in a similar fashion, if we have to go forward and think like we are already in 2022, and if we have to think about 2025 or 2030, and we already have National Health Mission goals to reduce the mortality and morbidity from tobacco and non-communicable diseases, do you think the current strategies are equipped or good enough for us to reach those targets?
No, as I said, like strict enforcement of law is very important. It is liberally available outside. That has to be taken care of. If not, you cannot mitigate these people. Not only transgenders, we cannot restrict people using from this tobacco products if you don't strictly enforce law. So that is very important. Second is behavioral change communication. And third one is harm reduction, like usage of alternatives. These things, and psychological counseling. These four things is mandatory, and we have to do all these things so that we can avoid, like you said, avoid the damage to the health industry or the economics.
Yeah. But when you say alternative products or alternative reduced risk alternatives, do you think the current government or the current policies are looking towards that direction? Because when we talk about reduced risk alternatives, we quickly think about nicotine replacement therapies.
Yes.
Even if we talk about nicotine replacement therapies, as we discussed, they are not currently available either at a discounted prices or subsidized for low income groups or freely distributed for low income groups. Do you think there is any shift in the current thinking by the governments to reach those 2030 targets? Are they going to bring about such policies? Are you aware of such thinking?
I don't see anything like that. With that, it is a sad part, but sad truth. But we have to accept it. They are not. A lot of countries now. In the past 2-3 months, we are seeing UK and other countries are legalizing and channelizing it. This is very important. Channelizing the use of nicotine replacement therapy or system, whatever it is. We are using a lot of drugs for treatments like morphine or pethidine or something like that for cancer treatment or any treatments in your operation theater. We are using all these kind of narcotics, which is banned for public use. So likewise, as a therapy, you can use this nicotine delivery system as well. We can channelize in that way, so that you need to have a prescription to have a system. So we need to have that kind of approach rather than like blindly putting ban on nicotine delivery systems, saying that it is creating dependence among the individuals. So, but if we are doing that, first and foremost, we have to put a ban on sale of tobacco, not to minors. It should be like entirely have to restrict or ban on tobacco sale, which is not happening.
So a revision on our current thinking about the current policy making is definitely the need of the hour.
Yes.
Because to meet the targets in 2025 and 2030, the current thinking, I strongly believe, is not going to take us there.
Yes. Feasibility is important, right? We can create any number of laws, but one has to follow it. So if a smoker, you cannot just like that. If you form dependence to something, we need to have some method, process to withdraw him from that kind of dependence. So we need to think in that way rather than like just putting a ban on something. It is not going to help us. It is going to create a chance for this unorganized sectors, and they'll make business out of it. So anyway, it is going to available.
Apart from this particular angle, how can we address the low quitting rates? Because you highlighted the behavior, communication, and counseling parts. That alone is not enough, I believe. What additional and novel strategies or smart strategies in today's context of pandemic imposed restrictions, and pandemic also triggered COVID quit kind of movements where additional motivation factor was imposed on people because you're staying with family, you no more can hang out with your buddy groups and cigarette group workspace channels where you have more opportunities either to smoke or do something else, but now you are in imposed environments. In one of my studies this came out in the qualitative discussions. But apart from this backdrop, COVID quit has come out as one of the most important COVID output for tobacco. So in that context, what are the other novel strategies other than behavior change communication, always asking the individual to do? Other than that, what are the other things the government can do to enhance and amplify that motivation and willingness to quit?
As you said, COVID quit, like we have an evidence that 1.2 or 1.3 billion is dying because of secondhand smoke. That is like someone close to us who's accompanying you to a tea shop and you're smoking, and that guy is getting affected because of that. So we need to think a different strategy, maybe we can attack Indians emotionally. That will work out.
Like you admit you are totally emotional. Okay.
Maybe it is not working. Like if you smoke, you will die. Maybe if you say, like, if you smoke, near and dear ones will die. That will work better than that, I guess.
Okay, my last point of interest, because our age of initiation in our study is also found to be 20 years. It is very concerning to me. And on average, Indian youth also having an exposure to tobacco product, and an average age of initiation for girl children in one of the study I have read was 80 years, because they are initiating with smokeless tobacco product, because it's a discrete product. Your mothers, your grandmothers are using it, is lying in the house, so they are getting exposed and getting initiated at 8 years for girls with smokeless tobacco product, and for boys it is quoted as 11 years. So it is a concerning and alarming factor. With that background, just raising awareness alone again seems to me to be not working. So in that context, I think we need to reshift our thinking and look for more appropriate strategies. And again, in this context, tobacco harm reduction looks a more feasible thing. Even if someone is trying to experiment at that age, if it is a reduced risk alternative product rather than a product with 7,000 toxins, 70 of which are carcinogenic, that looks like a more acceptable or less public health challenging situation. Yeah, absolutely. So this is one more thing we have to focus on this. And going forward, when we complete our final study and come out with this, the way forward, as we discussed already, we should raise some actionable points. To summarize that, what are the 2 or 3 actionable points that can emerge from our study according to you? Actionable points from our study. Like publishing manuscripts, so that evidence is available for policymakers. And with that we can like in our with our evidence, we can give recommendations and we can present it to the policymakers. And we can further explore things like we can explore different angle dimensions which we might missed in this study. With our experience, we can further explore that. As a public health specialist, that is the 2 best possible way I can see we can do it in our reach. Yeah, even I agree with you. And taking it forward, we can also try to again go back to the same community with our findings and call for another level of focus group discussions. Yes. These are our findings after conducting this study among trans peers. looks like a significant problem of tobacco use, and we can invite their own solutions, like what can we do with this data, what kind of solutions do you think will be appropriate, so that we can start hitting the problem. And with their involvement, maybe we can turn the tide towards this particular epidemic and start reversing the epidemic. Because even in the COVID pandemic, Dr. Shiva, if you remember, there was so much of panic in the earlier days that tobacco users are more at risk of being infected
Lung
with.
infection.
Yes.
Lung infection. Yeah.
Yeah. Is it still applicable in the context of Omicron?
Yeah. Age and smoking. Age and smoking has been considered as a factor which worsens this COVID infection, and that too lung involvement.
But in the Omicron, it is more about upper respiratory tracts, right? It's not involving lungs.
But this are all like each and every week they are changing their opinions, and we are getting a lot of controversial statements from because nobody is aware of the entire. We don't have that understanding about this COVID. Like today we may say something, and tomorrow we may say something, and there is one more other variant which has been mutation has been done, has been happened over in the Omicron. So we cannot predict all these things. We cannot say like this will not affect your lung. This is what happened initially, that you'll have upper and lower respiratory tract infection. Suddenly they say like it affects all the system, including your kidney, liver, heart. So we cannot predict all these things, and we cannot arrive at a conclusion at this point of time about this COVID, because it is showing a lot of dimensions. So definitely smoking is a risk factor.
Otherwise, Omicron or not, COVID or not, smoking is a risk factor for a lot of diseases, right?
Yes.
Every year, annually, malaria, HIV, AIDS, tuberculosis, and all things put together equates the number of deaths caused by tobacco.
Yeah.
And to reverse the tobacco epidemic, we have to strictly focus our attentions on prevention, as well as preventing the uptake of new users, right? Yes. So how, apart from the people who are currently using, we are talking about harm reduction. Are there any novel strategies, according to you, to prevent the uptake of new beginners or new people initiating a tobacco product?
We have to attack them at early ages. Like we have to do health education at schools, because the age of uptake is around 20. So if we educate this 10th and 12th students properly, I think the uptake we can reduce with that. Other than that, I don't see any possible reason to to reduce this uptake of tobacco products. Because we have to attack them. One is primordial prevention. That is like by law you have to enforce, and you have to make sure it is not available for this age group. And second one is we have to educate them at early age about the harmful effects, about the dependence, so that they'll not take up.
Okay. So the message is, to conclude our talk today, tobacco use among transgenders in Chennai is alarming. Yeah. And the age of initiation is around 20 years. And current usage is around 65%. And the intention to quit is very low. And all these findings, which are at this stage preliminary, we are running in-depth analysis. Right now, direct us to take a deeper look into this issue. And this warrants attention from the policymakers and from Association for Harm Reduction Education and Research. In this monthly webinar in January 2022, we are committed to bring this issue to the attention of policymakers, because harm reduction is a human right, and transgenders are being subjected to varieties of discrimination, minority stress. They use tobacco products as one of the coping mechanisms. And that could be the reason they are 3 times at higher risk of using these products, and becomes pertinent for us as part of this association to educate them and empower them with right information. And with this, I would like to thank Dr. Sivaguru, Associate Professor, Department of Community Medicine, for taking his valuable time to discuss with us a variety of issues related to tobacco use, as well as public health policy making dimensions. And I thank all the participants who joined today on this webinar series. I thank Arin for supporting us in the technical backdrop. And we would meet you again once again with a new speaker and new topic next month. This is me, Dr. Shri, signing off. Thank you so much. Thank you.
Thank you.